So I have a severe case of imposter syndrome right now in this room. I'm a genetic counselor with Illumina. I work in medical affairs, but I am very overwhelmed by everyone's excitement and enthusiasm and all your dedication to this one genetic condition. And I say that because a lot of the work that we do is with groups like this, but I don't know any other groups for one condition that are as kind of far along or as well coordinated as this group is. But if you think about how many rare diseases there are, I mean, imagine 6, 7, 8, 10,000 of these groups in existence to help drive treatments for rare disease. It's just overwhelming. So I'm really honored to be here. And today is my birthday, and so I would rather be here than at home doing nothing. No. People feel sorry for me for being away from home on my birthday, and I'm like, this is kind of a cool place to be. So, as I mentioned, I'm an employee of Illumina. That's my disclosure. And I think everybody knows these statistics, but for those of you that maybe don't have the numbers in your mind, 6,000, 7,000 rare diseases, although I'll talk about the Rare X report in just a moment. Anywhere from 2 to 6% of the population is affected, just depending on what literature you look at. And half of rare diseases, at least that we know of, impact children. And if you look at the NICU specifically, which is where a lot of kind of the work has been done at the state level and trying to get reimbursement for genetic testing, if you look at the NICUs and the PICUs, birth defects or genetic conditions are the cause of about 30% of admissions and about 40% of all of those deaths. And a majority of kids, not a majority, but close to a majority, pass away before they receive a diagnosis. And I think for the parents in the room, what's striking for me is that everyone that's here that's either treating a child or researching SLC6A1 or has a child, you've already gotten through your diagnostic odyssey. And I think the important point is, and this is a good reminder for me as we do our work at Illumina, is it doesn't just stop there. Clearly, it doesn't stop there. There's a whole new set of odyssey, the therapeutic odyssey that families have to go through. But when we look at statistics for the diagnostic odyssey, and these numbers are several years old, but I think they're still pretty true to form, the number of physicians and misdiagnoses that families experience while they're waiting for their diagnosis. But the number that our teams at Illumina really focus on is that $19,000 or so that are spent in diagnostic testing. So that's just genetic testing, any testing options to try to find an underlying diagnosis, with an average of around 13 genetic tests. The Rare X report, which some of you may have seen that came out earlier this year, I was interviewed as part of this to kind of get my take on how we at Illumina quantify or look at rare disease. And I should go back and say this. So for those of you that don't know Illumina, we're a sequencing company. So the bulk of what Illumina is known for is building sequencers. But we have groups, functional groups within Illumina, like my group, which we're focused on clinical applications. And so our work is looking to how we can take the sequencers and the platforms and the workflows that Illumina is creating and developing in conjunction with other companies and actually improving test utilization. So if we look at this Rare X report, they did a pretty in-depth study. They created an algorithm and looked to see if they could get a better count of the number of rare diseases. And so some people say, well, why is it important to have an exact number? It's important for various reasons. I think one big reason is if you can really show that there's an overwhelming number of rare diseases and that there's such incredible overlap with epilepsy, hypotonia, intellectual disability, that you need to have more comprehensive testing as your first line test. So that's probably the biggest argument for why this number is important to create. But along the lines with other evidence that's been published over the last 3 to 5 years, a majority of these rare diseases either are genetic or have a genetic subtype, but sadly, around 5% or so have therapeutic options. And so there's still 95% or so of rare diseases that lack well-defined treatments. And just as a review for those of you that maybe kind of don't necessarily, or you're not familiar with the different platforms for genetic testing, you have your old school single gene test, which back when I was in graduate school and started counseling patients, you wanted to do a Ashkenazi Jewish panel on a patient, and you had to order each individual test, 8, 9, 10, 11 genetic tests individually, and it was very expensive and arduous. But then targeted sequencing came around, where you could order one test and look at multiple genes that are related to a particular condition. And that methodology is still used very widely today, multi-gene panels for epilepsy, for Noonan syndrome, for other conditions. There's autism panels. But then if we move into the exome and the genome, that's where you're getting a much more comprehensive look. And there's pros and cons to all testing platforms out there, and there are certainly patients where a physician feels very confident in their diagnosis, and so it makes sense to do a single gene disorder test. It's cheaper, easier, you kind of know what you're looking for. But there are lots of different variant types that can occur, and I think, I forget if it was, maybe it was Dr. Greenspan's presentation around like the single nucleotide variant, the copy number variant, the indels. There are different variants that can all lead to the same condition in the same gene. And so if your test is not capable of detecting all variant types, then you might miss a diagnosis. And right now, whole genome sequencing has the capability to look at all variant types. That said, it's certainly important to kind of know that not all labs that are doing genomes are looking at all variant types. So for example, repeat expansions or short tandem repeats, even though it's capable, there's a capability there, there's a software to analyze it, not all labs are deploying it at this point. So as a clinician, a provider, even when you do a genome, if you're not familiar with that lab, it's just a good idea to look at the methodology and make sure if you're concerned or suspicious of a certain variant type being the cause, you need to know that the genome that you ordered is including that variant. This is internal data from our clinical lab at Illumina. Our clinical lab is really just doing samples that are either philanthropic through our IHO program or research studies that are going on. Sometimes we do clinical samples as part of research collaborations. There's sort of one-off providers that we do testing for, but around 700 patients, and when we looked at the variant distribution, as we would expect, knowing typical variant distributions, a majority are SNVs, but there are combinations of variants that if you were to do an exome, for example, you are likely to miss copy number variants. If you do a microarray, you're likely to miss structural variants. So you just have to keep in mind when we're thinking about genetic testing for patients, how do we maximize diagnosis? So traditionally, you have this kind of, I mentioned this specific pathway. When you have this non-specific intellectual disability, broad hypotonia, epilepsy, it just makes a lot more sense to have one test. And some labs are using right now a genome as a platform or a genome as a backbone, where they're running a genome backbone, but they're doing a virtual exome. And so the benefit of that is, if you can imagine, if the exome is negative or if you need to go back later on, you can unblind and look at the rest of the genome. The reason that a lot of labs are doing that is it's easier to update your labs, so you don't have to revalidate a panel every time you want to add a gene or take a gene off. But also you can expand much more easily when you have the human resources or the financial capabilities to start doing genomes on a more regular basis. So multi-omics is kind of the next phase of this, and there's a whole big team at Illumina that are working on different multi-omics in a research setting. There's some work being done with different drug companies. Cancer is a big area where Illumina is working in proteomics. But that's kind of the next phase for this, is once we get a sequence, a variant, then we need to know how that variant impacts the brain, impacts development through RNA and epigenomics. And on the right just shows the overwhelming number of publications. So if we look at researchers who are doing genomes And then, how many research doing genomes are also doing RNA-seq? It's a lot. It's like 70%. And so RNA-seq is a really big emerging area in genomic sequencing, but so are the other omics as well. But if we can't get a genome covered, we're sure as heck not going to get multi-omics covered by insurance. So utility is not just one thing. There's diagnostic utility, but as everyone in this room can attest, there's clinical, personal utility, economic utility, system utility. And for clinical utility, we look a lot at management changes, and that's where some of the, what kind of medications can be added or taken away, what kind of therapies can be started with a molecular diagnosis. In the NICU population, there's been quite a few publications that have come out over the last few years. If you're familiar with the Project Baby programs in California and Michigan, and there's in Florida, and there's some others that are popping up as well, there's really good evidence out there around diagnostic utility compared to standard testing in the NICU population, but also change in management. Similarly, for pediatric outpatients, we see the same thing, higher diagnostic yields in genome compared to standard testing, which may or may not include an exome, but also clinical utility or change in management. And if we just look at neurological indications, the one paper that's missing on here is the one that just came out from Anna Lindstrom's group, which it just came a month ago, I think. But overall, we're seeing good diagnostic yields in a variety of neurological indications. So I feel like we can argue we've got the diagnostic yield. We still need to increase it. It still needs to be higher. But we've got good evidence on diagnostic yield. What the payers are telling us is that we need more clinical utility. We need more change in management. And then they continue to move the needle and say, well, we don't just need immediate change in management. We need to know the 1 year, 2 year, 5 year impact on the patient care. And so that's where Illumina collaborates with different organizations to try to identify research opportunities so we can, hey, we'll support genomes, and then maybe, you guys do the outcome work. And if we can try to show the payers that there is true impact on outcome, then maybe they'd be more likely to cover genetic testing the first time, versus what some of the stories have been today is, like Kimberly's story. Getting turned down, it's not covered. That's kind of the goal, is that it's a no-brainer. If you want it, it gets done. And there's cost-effective data out there showing that first-line genomic sequencing is cost-effective and has a higher diagnostic yield compared to different strategies for standard of care testing. This is not updated, but I thought, in case anyone was curious, kind of where are we globally with coverage in the US? There's the two buckets. There's the NICU bucket of Medicaid and commercial insurance companies that have come out to say, yes, we'll cover rapid genomes or rapid exomes. And then there's the general coverage, which may or may not just be specific to rapid whole genome sequencing in the NICU. But what we're finding is that there is coverage, and like every month, every other month, we hear and out in the news and from different conversations, oh, this payer now has a policy. But unfortunately, even when the policies exist, there's just poor utilization. And an example of that is Harvard Pilgrim, which is now called Point 32 Health in the Boston area. They had an exome coverage policy, if you met criteria, and they got into a risk-sharing agreement to show that if they increased their coverage to genomes, the agreement was that we could prove that you would not actually be spending more money in the long run, that there would be either a cost savings or a cost equilibrium. And the sad part is no one used it. And as much as they communicated the information with their provider network in the Boston, the Massachusetts, New Hampshire area, Connecticut area, there just was poor utilization. So even when there is coverage, there's poor utilization. And that's unfortunate. And so lastly, I'll just touch on guidelines, because guidelines are kind of the first step in the clinical world of trying to get improved access. This was a really big deal in the field. This came out last year from ACMG. They did a meta-analysis, a systematic evidence review, and then this is ACMG's first ever evidence-based guideline, where they did this used this methodologist and went through this arduous process of a systematic evidence review and then generated the guideline. And that's kind of where they're going. They want their guidelines to be much more evidence-based. And this was really great. I mean, you would look at this and probably think, oh, that means I can get a genome covered because a medical society says so. But we all know that that's not the case. It's going to take many, many years for this guideline to actually move into making a change and increasing access. But it's a start. They acknowledge the clinical utility. They talk about exome and genome. Genome is not called out as being, the best. It's just together exome genome, which I think is huge. We just don't have the access yet. And this is just a breakdown. I'll skip over this, but other societies have come out with guidelines around exome and or genome sequencing, and they all kind of agree about the first or second tier option. Additionally, the National Society of Genetic Counselors just last month published their practice guideline on genomic testing for epilepsy. And so they recommend exome or genome sequencing as a first or second tier test. Yes, I'm a genetic counselor, but the GC guidelines aren't going to have a substantial impact on reimbursement and payers, but it's a start. And it's based on really good evidence from Dr. Perduri and the Boston Children's Group. They did an evidence review. But again, there's so much more left to do. So we need a lot more evidence. And from everything I've heard today, there's certainly a lot of evidence generation happening. There's a lot of therapeutic research happening. But we know what the field needs is more kind of indication-specific diagnostic yields. So the payers will say, great, IDDD, that's like, most kids that go into a genetics clinic. We need to be much more specific. What are the indications that we need? We need genomes to be considered for as a first tier. And then what is the impact that could have? What is that change in management? If it's just personal utility for the healthcare provider, the patient, the family, their entire ecosystem, that's great, but the payers don't look at that necessarily as number one priority into why they should have reimbursement. And that's unfortunate. So we need some more real-world evidence, more evidence around multiomics. Long-read sequencing is kind of a new space for improved genetic diagnosis. Change in management, economic utility, personal utility, and then more about just real-world implementation. So what does it look like to bring whole genome sequencing or whole exome sequencing into a non-genetics clinic? What does it look like for a NICU to bring it in? What does it look like for an outpatient neurology office to bring it in? It's not just checking a box and ordering, a metabolic panel. It's much more complicated. There's consent, secondary findings, incidental findings, variants of uncertain significance that people are really freaked out about. And so how can we develop tools to help with education, improve access, improve those workflows so that patients that come in, like Kimberly's child, first time, meets criteria, gets the testing done, we have the capability of doing it, insurance will cover it, boom, it's done. And it saves the family a lot of time. That was it. That's Sawyer. Isn't he cute?